The Center for Tropical and Emerging Global Diseases, which is his outfit, and the Health and Medical Journalism program at Grady College have been doing these series for 8 years now, which is hard to believe. Now, when we thought about this series, we called it Global Diseases, Voices from the Vanguard, because we really were interested in diseases of neglected peoples around the world. And while there are plenty of neglected people in our own country, we were thinking of it mostly as an international series. And this is the sort of thing that Ben Parks signed up to study work on when he became an EIS officer at CDC. That's Epidemic Intelligence Service, and they are the famous disease detectives of the Centers for Disease Control and Prevention. And when I first met him, I think he was just a couple of years past his EIS officer training, and he'd stayed on as the head fungus guy there to do epidemiology. And most of what he was working on was in faraway places. And I'm pretty sure he didn't think, and I certainly would never have anticipated, that he would get, that the highest profile thing he's worked on so far has been right here. Because typically fungal diseases, we're just not the epicenter of that sort of thing. So he has quite an adventure story to tell you about solving a mystery and about how public health apparatus can spring into action when something untoward comes up and threatens the health of people here or in faraway places. It's a big reminder that when we say global, global includes the United States. Now, just before I drag Ben up here, I just want to say there is the typical reception following. That's free, open to the public. The food is really good. It's, I hope, going to be in Demosthenian Hall next door. There's a little problem with the door lock right now, but definitely by the end of Ben's talk, I'll know whether we're going to be eating high-quality munchies over there or in the back hallway here in this very same building. We'll figure it out. Anyway, please welcome Ben Park.
Thanks, Pat. Thanks for the invitation. I'm really excited to be here. My wife actually went to the Grady School, so she would always tell me about all the really interesting things you all do here, and it's just a real pleasure for me to come back here to give you all this lecture. And thanks also to Dan for the invitation for this talk. As Pat said, I'm going to talk about this outbreak, and I'd really like to discuss a little bit about how public health can spring into action, as Pat said, and kind of what we do, what does CDC do, and how do we affect people's health here in the United States, as well as abroad. Well, before I start, I would like to acknowledge all the people that were involved in this outbreak. It was really the work of hundreds of employees at 23 different state health departments, over 300 employees at CDC alone, FDA and employees at the Department of Health and Human Services, as well as experts in fungal infection, and over 1,000, probably closer to 3,000 physicians and other people responsible for patient care throughout the country that were integrally involved with this outbreak. This is a quote from Dr. Lawrence Altman, who many of you know is a health writer for the New York Times, and this really kind of sums it up. It was one of the most shocking outbreaks in the annals of American medicine, and hopefully I can describe that a little bit for you as the talk goes on. Well, first I want to talk about what does CDC do. I think a lot of you know that CDC is right down the road in Atlanta, but what do we do? We do a lot of things. Here's a little bit of propaganda for you. CDC works 24/7, save lives, protect people, and save money through prevention. And Pat mentioned one of the ways we do this, which is through something called the EIS, which is the Epidemic Intelligence Service. And these are the kind of the CDC disease detectives that you hear about. I started at CDC as an EIS officer. I know I look like I'm about 20 years old, but I'm actually about double that. And I started right after my residency. I came here from Ann Arbor, another college town, to work in this EIS program. And that was actually about 11 years ago, and I've been working on outbreaks and fungal diseases ever since. So fungal diseases, that's my kind of niche at CDC where I work. And this was a huge outbreak of fungal disease, which is how I got involved. But when you think of the disease detectives, the EIS officers, you might think of Kate Winslet. And we don't have any EIS officers that are this good looking, by the way. But but Kate Winslet in the movie Contagion. Did any of you see the movie Contagion? Because I definitely saw it. I thought it was awesome. But Kate Winslet plays actually an epidemic intelligence service officer, and she goes to Minnesota, and she goes all over the country, I believe, tracking down this new pandemic virus. And so these people actually exist. These are EIS officers, and for those of you that are in grad school or undergraduates and you're interested in a career in public health, EIS is one of the ways you can get involved with public health. It's a program that's run through the CDC, and I can tell you more about it during the break if you're interested. And we have our own EIS officer that was really kind of one of the point people in this, and I just want to point her out here. This is the woman, her name is Rachel Smith, and this is what she said in an interview with Fox News. She said, "It's not often that you get to work to directly see the impact of your work in public health. But during this outbreak, I knew that all the work we were doing, the late nights and all the effort, was really going to make a difference in people's lives." And that's what public health is about, is making a difference in people's lives, kind of from behind the scene, actually. You don't have your face all in the media, you're not seeing patients directly, but you're the one who is hopefully impacting many different people in the public through these programs. So let's talk about the outbreak a little bit. How did I get involved? Well, September 20th, 2012, which was hard to believe it's almost 6 months ago, or more than 6 months ago, the Tennessee Department of Health called CDC to discuss an unusual case that was reported by an astute physician. A lot of these outbreaks kind of start from an astute physician who notices that something is wrong, something is different. And this was a patient with Aspergillus meningitis. So meningitis being an inflammation of the spinal cord, an infection. You think of meningitis, especially on college campuses, you think of epidemic meningitis, meningitis that causes thousands and thousands of deaths in Africa. These are the ones that are passed on from person to person. It's a very severe infection, and it can lead to all kinds of terrible things, including death. And this patient had one with Aspergillus, which is a mold. And this is quite a common mold that you can find almost anywhere. It's an environmental mold. But this patient had this really strange meningitis. And Aspergillus does cause infections, but usually in people that have very weakened immune systems, people who have had undergone chemotherapy, or people who have had a bone marrow transplant. Now, interesting thing about this patient is this patient had had an epidural steroid injection for back pain. Now, back pain is an extremely common condition. There are millions of Americans that have back pain. And actually, many of them get epidural steroid injections. But this is somewhat of a strange infection. As I said, meningitis is a very deadly disease, but actually meningitis due to molds is very rare. And so immediately, this astute clinician thought there was concern for contamination somehow. And she didn't know exactly where. It could have been any number of places, as I'll discuss as the talk goes on. But one thing that stuck out to her was that the steroid was a compounded medication. Well, what is pharmacy compounding? Pharmacy compounding is the extemporaneous combining, mixing, or altering of drug ingredients by a pharmacist in response to a prescription for an individual patient. This is kind of called the triad of compounding. Now, compounding is a traditional component of pharmacy practice. This usually occurs in pretty much any setting where there's a pharmacy, in a hospital, in a community, also sometimes for a home infusion. And you can think of an example of pharmacy compounding as a local pharmacy making an oral suspension for children. So for those of you that have kids, when your kid gets sick and they need amoxicillin, you go to CVS and they mix up a bottle, they shake it up and give them a tablespoon twice a day. That's compounding. They take powder, they take antibiotic powder, and then they make a formulation for your kid specifically, and at an appropriate concentration and an appropriate amount. Now, pharmacy compounding meets, as you can imagine, it meets needs that cannot be met with commercially manufactured drug products. A drug, Pfizer can't make every single formulation of drug that it would be necessary for a child to receive amoxicillin. It's just not possible. That's why there's compounding, so that you can actually mix it and give a custom amount to a patient. Well, actually, compounding has a broad scope, though, where we're just talking about an oral formulation. That's kind of in the non-sterile category. But if you look at the sterile category, this can actually involve many other different types of medications, including ophthalmic solutions. These are things you use in your eye, irrigations, cardioplegia solutions. These are things that you use during heart surgery when you actually stop the heart from beating so you can operate on it. And injectables, like things like anesthesia, antibiotics, electrolytes, flushes. These are all things that are used on a daily basis in hospitals, but a lot of times they're compounded. And oftentimes before this, they were compounded by the hospital pharmacy. Well, what has happened? The compounding industry has changed and is continuing to change. There have been a number of drivers of these change. First is an organizational or operational driver, where the hospital or the clinic needs to outsource some of these things because administratively they can't handle it anymore. There's also a clinical need for commercially unavailable product. For example, there's a critical product that's in shortage. This has happened many times before. Or there's a customized product, for example, an oral formulation of an antibiotic. But importantly, there's also another driver, which is an economic driver. Compounded drugs, for many different reasons, have lower price than the manufactured equivalent. So many hospitals, many clinics turn to compounded medications because they're cheaper. It makes sense. There's a lot of pressure on hospitals these days to make money. So what has happened? Well, compounded medications, as a result, have become more common. There's been a recent expansion in scope in the nature of activities. It's actually been an explosion. In 2012, there were 7,500 U.S. pharmacies that were specializing in advanced compounding services. And there are about 3,000 of these provide sterile compounding services, sterile compounding being the highest risk for contamination. You can imagine, if something's sterile, it's supposed to be sterile, it's going into your vein or somewhere else, you need to make sure that it's sterile, but these are the highest risk. So in the old model, that's that first row of graphics, the old model used to be a hospital that would do an in-house preparation with an individual prescription for an individual patient, and usually it is orals or even a topical formulation, a cream, and it was distributed locally. But what's happened in the recent years, and this has really only been in the past probably 10, 15 years, is that it's moved to an outsourced model, where instead of being in a hospital, it's now outsourced to a larger company. It's produced in bulk. Instead of having oral or topical, it's now sterile products, and these are distributed widely to multiple different states. Well, as you can might imagine, this is the topic of the talk, there have been outbreaks linked to compounding pharmacies, dating pretty far back, but this graphic just shows over the past approximate decade what has happened. And you can look, it's kind of a busy slide, but you can see the small print that these are a number of outbreaks that have happened over the years. Most of these outbreaks are fairly small, with 10 people, 11 people, 6 people, 8 people. But then you'll notice in 2012 there are 2 very large outbreaks, the one I'm talking about today, and then another one of eye infections that was actually related to another compounded medicine produced in Florida, and that had 43. So that was almost like the harbinger of the massive outbreak that happened here, which was over 700 cases. Well, what about the compounding industry regulation? Regulation is very complex. The authority is ambiguous and oversight is fragmented. So you can imagine, if you're a compounding pharmacy, that's a perfect environment to thrive. State boards of pharmacy are thought of as a primary authority, where sterile compounding is subject to state regulatory and professional standards, and they're not subject to federal pharmaceutical manufacturing standards. So there's kind of a gray area here. And there's also variable enforcement of these laws. It varies state by state. A lot of it depends on how much resources the states have to enforce these rules. Now, FDA enforcement is considered when the scope of pharmacy activities raise to the kinds of concerns normally associated with a drug manufacturer. And what happened in this outbreak is, as we'll go on, it's found out that actually the amount of compounded medications here was actually quite high and almost on the level of a drug manufacturer. So I'm going to go over the first 2 weeks of the outbreak. As I said, September 20th was the day that we first got the call. This was really a quite dramatic period for me especially. This was probably the most exciting 2 weeks of my 11-year career at CDC, where things were moving so fast and things were happening so quickly that it's really amazing how things settled out in the way that they did. Hopefully I can just give you a taste of what that was like. Again, September 20th, the CDC was contacted by the Tennessee Department of Health regarding a single patient with culture-confirmed Aspergillus meningitis, and they had their epidural steroid injection at a single ASC, ambulatory surgical center. So these are these places where you go, many of you may have been there, where you get a specific procedure done. In this case, this is a center, a clinic, if you will, that specialized in epidural steroid injections. Now, this patient had their injection on July 30th and was admitted into the hospital in late August, so almost a month afterwards. A few days went by after we talked to Tennessee. We said, okay, this is a very interesting case. We're concerned that there's something out there. Please go out, look more, find it. If you see anything else, let us know. So on September 25th, 5 days later, further investigation by the health department identified 7 additional patients with meningitis at this same center. So that's definitely concerning and raised our concerns a little bit. Now, there are a couple things about this, though. This is an unusual clinical cluster. And all these patients were characterized with a subacute onset of meningitis. So when you think of meningitis, it's usually like people get sick and they die really quickly. But in these patients, they came on very slowly. People had kind of a headache. They felt really badly. They maybe had a little fever. And it's over really a course of days to weeks to even, to many weeks even, where the people got progressively worse. The other thing about this cluster is that 4 patients had posterior circulation strokes. A stroke, as you can imagine, is a common event. But usually when you have a stroke, it's in a distribution of your cerebral arteries that cause kind of what you think of as a stroke. Someone has, half of their body goes limp, or they can't speak. These people had strokes in the deep part of their brain. And the deep structures of their brain are actually probably the most important structures. They deal with a lot of the nerves from the brain go through there. So when you have a stroke in the deep brain, in the posterior circulation, this is quite traumatic. And the other thing that was unusual about this was that all of the cultures of the CSF were all initially negative. So actually, except for the first patient that had Aspergillus, they didn't know what these other patients had. Now, there are a number of common links. In epidemiology, we always think about, okay, what are the common links? What are the things that could tie all these together? Well, they had all undergone an epidural steroid injection using methylprednisolone acetate, I'm going to call that MPA in this talk, from the New England Compounding Center. But there were also other common exposures, including something called contrast material, which is a dye that's injected by the anesthesiologist to make sure they're in the right place. Povidone iodine, that's like betadine solution, something to clean the skin. Even lidocaine, which is a skin numbing agent. Spinal needles, epidural tray kits. So a lot of things that were also in common. And so we couldn't, although we were concerned about the steroid injection, we couldn't know for sure what it was. So as I said, this was a very unusual cluster. And our immediate concern was for some type of contamination, because this was an environmental mold and it was very unusual. And there were 2 main types of contamination that we considered. One is extrinsic contamination, where there was a heavy burden of mold spores on the packaging, or in the operating room where they did this in the surgical site. Somehow, maybe the HVAC blew mold spores onto the patient. And then we're also considering that there was intrinsic contamination of the medication itself. So there are still many different hypotheses at this point. Now, the good thing is that there were a couple prior fungal meningitis outbreaks that we're able to kind of compare this to and get ideas from. One was an extrinsic contamination event in Sri Lanka following the 2005 Indian Ocean tsunami. And this is a really interesting outbreak where a moldy closet led to Aspergillus meningitis in pregnant women that were undergoing anesthesia for delivery. And among these people, about 60% of them died. So this is a very severe, very fatal outbreak. And then there was also a case of intrinsic contamination in 2002. There was an outbreak in North Carolina where there were 5 cases of another type of fungus called Exophyla, which was a compounded steroid medication. And this was distributed locally just in North Carolina. So there's two different models that we were looking at. Again, in this outbreak, about 40 or 50% of the people died, so very severe outcomes. So what were some of the things that we were considering? Well, there's the kind of the local clinic-based contamination, but when we went through and talked to the clinic, there was no new construction. So a lot of times when you do construction, there's all this dust and mold that goes everywhere. There are no problems with their HVAC system. There's no flooding, no changes in practices. There's no clustering by any physician, although there were many common products, as I mentioned before. Now, what about a product-based contamination? Again, a product-based contamination could be more widely distributed. There are many common products, again, and we thought that a compounded steroid was probably the most likely, but again, there are many other products in a national distribution that would make us concerned for a wider problem. So getting back to that timeline, getting back to September 25th, this was a busy day, FDA was notified. We had a call with the company to talk about this investigation, and the company told us that this is terrible, but they hadn't received any reports of illnesses, and there were no concerning results with their sterility testing. Well, the next day on the 26th, the company issued a voluntary recall of the 3 lots of medication that were used. And they provided a list of the 76 facilities in 23 states that received the same medication from these same lots. Now, this is important because one of the things that we do as epidemiologists is that we look and we do what's called case finding. We see, are there other cases out there? So we use this list to actually call up physicians and find out, you use this steroid. We have a cluster of people in Tennessee with this infection. Did you have any cases? And this is one of the things that we can do to try to find out, well, if they have other cases, because it's such a rare infection, it might be linked. So on September 27th, the North Carolina Department of Health let us know that there was a patient with meningitis of unknown etiology that following an epidural steroid injection at a North Carolina clinic. So this was our kind of, I was talking to my wife on the way down about aha moments, like in science, I give an aha moment. Well, this is kind of our, oh crap moment, if you will. I mean, because I remember looking at Rachel, the woman that you saw before, and we were talking to this physician, and our jaws just dropped on the ground, because this is when we knew that we had a bigger problem than just at this one clinic. And it's a really interesting story behind this. We actually got really lucky. What happened was we were calling these clinics, and we're trying to find out if there were any other cases. And we talked to a physician who just happened to be on call the night before at the hospital. And one of his patients, who had a history of epidural steroid injection, actually showed up because she had meningitis. And it was only because he was on call, and he actually recognized that his patient was there, that he was able the next day when we called him to say, yes, actually I do have a patient, because if he hadn't been on call, he never would have known that. Now, granted, we probably would have found it another way, but this is the kind of the things that kind of fall into place in an investigation. It might have been a couple more days before we had known that this was widely distributed. And I remember talking to him. As I said before, a lot of these patients had what's called a posterior circulation stroke, a very strange place to have a stroke. And we were talking to him, and he said, yeah, this patient just came in last night, and I knew her from my practice, and the strangest thing happened. She had a stroke last night. And then, right then it was again, my jaw just dropped to the ground, and we knew that this was related. So September 28th, we began notifying all the patients who had been exposed to this medication about this outbreak. But the thing about this is that we still didn't really know what the exposure was. Granted, we were very concerned about this steroid, but we didn't have concrete evidence. We didn't have like a vial that had mold in it yet. We were still, right now it's just a bunch of people that had a very strange illness, and we thought that they were linked. The other thing is that we didn't even know what this organism was except for one case. So all these people, usually in epidemiology, you can link them at least by the organism. At least they all have the same strain or something, and you know that they're all linked. But in this case, we didn't even have that. And then until October 4th, when FDA announced that they had found fungus in unopened vials of this medication, methylprednisolone, CDC activated their emergency operations center, and we began notifying everyone, all 14,000 people approximately, of their exposure. Well, this was truly a major outbreak response. This was the largest healthcare-associated outbreak reported in the United States history. It was really a massive undertaking. Again, over 300 staff at CDC headquarters. And I say here more than 1,000 staff nationally. It's probably more than 3,000 people were involved in this, involving state and local health departments, clinicians, nurses, and administrative staff. And this was our concern. Our concern was that there were 14,000 people exposed to this contaminated medication. Of the first few people we knew about, there was a delay in diagnosis, and many of these people had adverse events. So of the initial 9 patients that were identified, 4 developed a stroke and 3 died. So we did our math pretty quickly and we realized this could be really bad. Again, there was limited experience with this type of infection, and again, known outbreaks of this had about a 40% mortality. So there was a lot of concern that this could result in a lot of morbidity and mortality. So there are a couple of major components to our public health actions. The first was the patient notification, and I'm going to talk about all these in a second. First is the patient notification, also clinical guidance, laboratory support, and communication. So just talking about these quickly. Again, the medication was recalled on September 26th, but this was really not enough. We needed to do more to notify these people. So CDC launched a collaborative effort to notify all the exposed patients of the nature of their exposure and the indications to seek medical care. And this was conducted mainly through clinic staff and state and local health departments. Again, over 3,000 people throughout the country were involved with this. And our goal was to diagnose people early so that they could start treatment and reduce their likelihood of getting one of these severe outcomes like stroke or death. And within 10 days, really a huge effort by everyone involved, all 3,000 people, we were able to contact over 90%. And then I think within 2 or 3 weeks, we contacted over 99%. So really a massive, massive undertaking. This is a picture on the right of CDC Emergency Operations Center. There's really, if you ever get a chance to go to CDC and you take a tour of the EOC, it's like a big row of computers and banks. It's kind of like what Hollywood would imagine the EOC to be like. It is like that. It's just a bunch of people can man phones and call and staff for big outbreaks like this. The other thing we did was we developed clinical guidance, and this was done really on the fly. I mean, there's been no experience with this type of disease. So we needed to tell clinicians something. We needed to tell them, okay, I've diagnosed this patient now with this meningitis. What do I do with them? So what we did was we engaged, world experts world expert mycologists. These are experts in fungal disease regarding the best practices for the diagnosis, treatment, and management of this disease. And again, this is based really on little to no data, but again, on a theoretical benefit. We knew about the mold, and we knew where it was. So we chose the medicines that we thought would be most active against these molds in the spinal space. So this resulted in real-time development and dissemination of recommendations for patient care on the web, and so that clinicians could readily access this. And this was great because it was able to evolve with a rapidly changing outbreak. When there was new data, we were able to post it on the web and get it to clinicians, to the people who really needed to see it. Laboratory support was also critical. Fungal diagnostics for the CSF do not exist, but at CDC we developed a new test, a PCR test in 2 days that quickly identified the main fungus as Exerohilum rostratum. And this is a picture of this fungus over here. This is the actual fungus that caused the disease. And this Exerohilum is a very rare fungus that's very rarely seen in patients, but it's common in plants. It's a pathogen that causes rotting in plants, so it was very strange to have seen it. And the lab processed over 1,000 specimens during the outbreak. Well, the other thing that was really critical, especially for those of you that are in the Grady School, that was important, was communications. And this is really, it's hard to stress this enough, but it was really one of the most integral components of the outbreak response. And there were a number of features of the communication strategy that involved the website, interacting with the media, both print, electronic, even blogs were engaged about this. We sent out health alerts to clinicians through emails, blast emails to professional societies, and also scientific publications, which is a traditional way of getting information out there. And the goal of our communications was to provide transparent, timely, and trustworthy information to the public. And for those of you that are interested in health communications, this is really a poster child for what can go right, I think, in an outbreak response. So just talk briefly about the current status of the outbreak. Well, this is a big slide, and there are a lot of states on here, and there are a lot of people, unfortunately. But what this is the case count as of a couple of weeks ago by state, and the total case count by state, and then the different forms of the disease. And one thing about this outbreak that we found was that although most of the people started off with meningitis, actually this outbreak evolved to something that's where now actually most of the patients have what's called a paraspinal infection, which is really like a pocket of pus sitting next to the spinal cord. So it hasn't spread into the spinal cord column and gone up and down the brain. This is just a pocket of pus sitting there, and this has been a real challenge because a lot of the patients, as you can imagine, got their injection for chronic low back pain. Well, how does a paraspinal infection present? It presents as back pain. So it's almost impossible to know what is someone's underlying pain versus what is actually, a time bomb sitting next to their spinal column. But what we found here, so what this shows is there, again, over 700 patients have been infected, 720 total patients with 48 deaths, and this is as of a couple of weeks ago. This is what's called an epidemic curve. And epidemic curves are done by epidemiologists to characterize the epidemic in terms of numbers of people over time. So the x-axis is the week of diagnosis. This is kind of the timeline. And the y-axis is the total number of cases. And you can see this is a very typical kind of point source outbreak epidemic curve where there's kind of a slow rise and all of a sudden a big peak that happened right at the end of September and then a trail off. But the other thing you'll notice is that these colors differentiate the different forms of disease. I just said that a lot of people are getting what's called a paraspinal infection, and those are these green bars here. And if you sum up all those green bars, actually the total number of those people outnumber the meningitis. So while this has gained notoriety as a fungal meningitis outbreak, it's actually really more of a fungal paraspinal infection outbreak. Because just of the massive numbers of people that have come down with this, what we call the second wave, which is the first wave being meningitis, second wave being all these people that have come in with these localized infections. So, I've talked a lot about what we did. We did all these things. We called all these people. We got in front of the media. But, when I say did we do anything, I really mean, I guess, did we accomplish anything? So this is a figure that was recently in a publication called JAMA, which was talking about really the need for a strong public health system. But in that argument for a strong public health system, they talked about the fungal meningitis and how it was important. So what this graph is, this is the epidemic curve, which you just saw, which are the bars. I think you're able to see that. And then the red line is the case fatality rate. So these are the people, basically the proportion of people that died according to when they were diagnosed. And what you'll see is that for those people that had their illness onset in early September, they didn't do so well. They had a high likelihood, actually, between 40 and 60% chance of dying. But then as the outbreak went on and it was recognized and this guidance went out to clinicians, these people were identified and people were started on therapy, that case fatality rate dropped down to almost zero. So indicating that actually we're able to save some lives. And if you do a kind of a back of the napkin calculation, we're trying to kind of firm this up, but we think that we probably saved over 100 lives in the United States by this coordinated public health response. All right, well, let's get back a little bit to pharmacy compounding and talk about some of the failures. Obviously, this was a huge failure of compounding. So the tip of the iceberg, if you will, they're the outbreaks. This one being the most notorious outbreak, but there are many others in that slide I showed you, especially over the course of the last 10 years. Then if you get a little bit lower down the iceberg, there are all these FDA and state enforcement actions on compounding pharmacies. The product recalls. You hear about all in the news all these times. Recalls of a certain medication. Sometimes pharmacies will have their license revoked for something, but it's not really necessarily tied to an outbreak. And then there are all these other warning letters that go out to compounding pharmacies. So this is all the stuff that we know about. But what about underneath the iceberg? How many outbreaks, how many illnesses really happen? And so as a result of this, I think one of the real benefits of this outbreak was that the media picked up on this. They picked up on this issue, and they picked up on the kind of bottom of the iceberg, if you will. And there have been a really good number of articles written in the Washington Post by Kimberly Kindy and Lena Sun that really shine a light on this. I'm just going to read these headlines here, and I'm just going to track how this evolved over the course of a few articles. February 7th, a little bit over a month ago, they wrote this article about compounding pharmacies, saying compounding pharmacies have been linked to deaths, illness, and safety failures for years. So again, this bottom of the iceberg, like really shining a light that this is a problem. Next, this is February 8th, the next day, FDA, there's an article by the same journalist that say FDA chief says pharmacy oversight is at a critical point. I don't know if many of you remember, but there were hearings on Capitol Hill about pharmacy oversight, and the FDA chief was up there saying basically that, you know, it's not basically saying that, you know, there are all this patchwork of regulations, and it's very difficult. FDA has no clear authority to do anything, and this was really highlighted by this article. Then, you know, a couple of weeks later, this article came out, which was talking about the pharmacy trade group. And the pharmacy trade group has been essentially a lobbying organization that has been, when regulations happened in the late 90s that allowed the compounding industry to flourish, they actually were one of the groups that strongly opposed any new regulation by FDA over the compounding industry. And so on February 21st, just about a month ago, this article came out. The pharmacy trade group shifts their position on federal oversight, essentially saying that they now agree that there should be federal oversight of this industry. And then recently, CBS News has done a tremendous work recently. In this 60 Minutes, I think it was just 2 weeks ago, I think it was actually a week ago last week, we did a whole 60 Minutes episode on the compounding industry and regulation of it. And so they've really also been able to shine a light on this whole topic. So what about the future? Unfortunately, I was just talking to Pat before this. The outbreak continues. We're still getting cases almost on a daily basis. So the 720 cases I just showed up here, actually it's higher now. You know, and we're updating our website frequently. So unfortunately, the cases are still rolling in. The good news is that the numbers are dropping off. Hopefully, there won't be a third wave of cases, but we don't know. In the other outbreaks that have happened, people were presenting with illness, you know, 6, 7, sometimes even later, months after their exposure. So it's really, I keep telling all of our partners on these public health calls, you know, this is not a sprint, it's a marathon. We really need to make sure that we're up for the task for following these patients for a long time. What about patients? Unfortunately, you know, patients face tremendous amount of anxiety. Both the infected patients, the patients who are unfortunately undergoing very terrible therapies, these antifungal medications to treat this infection are quite toxic. They can cause anything from visual hallucinations to liver problems to renal failure. So these are very toxic medications. And then there's a whole group of people, the rest of the 14,000 people that are the worried well. You know, as I mentioned before, how do you know if you have an infection if the presenting signs of infection are almost identical to what you sought the treatment for in the first place? The good news, though, is we're starting to hear about more and more people, more and more patients that are cured. And when I say cured, I mean these are patients that have stopped therapy, they're followed by their doctor, and there's no signs of this coming back. And we're just at the window now because the treatment is about 6 months of therapy. So we're just at the window now where people are starting to get off therapy, and we're starting to hear about more and more people that are being cured. Well, currently compounding pharmacies continue under this existing regulatory framework. And you know, it's important to you know, I've talked a lot about compounding pharmacies today, and it's easy to get the idea that compounding pharmacies are this, you know, evil industry, but that's not really true. Compounding is not the problem. Contamination is the problem. You know, there's nothing wrong with getting a compounded medication as long as it's safe, and that's really what we're trying to emphasize. As a result of this outbreak, there's new legislation that they're crafting on Capitol Hill to expand FDA oversight, and that's planned, that's in the works, and those discussions are underway, so I think that's good news. But regardless of that, outbreaks are going to continue. Actually on my way over here, I've been on conference calls all days about another issue that if you want to Google it when you get out of here, there's another medication that was recalled today because of a fungal contamination. So these outbreaks will continue. Even a few months after one of the largest outbreaks, the largest healthcare associated outbreak in U.S. history, these things still happen, and it's not necessarily a result of in some cases it is because of laxity, but a lot of times these things will happen, and because of that, it's essential to have a strong public health system in place that can detect and respond to this type of outbreak. So with that, I think I'm going to end it, and thank you all for listening to me today. That's a really good question. So the question, for those of you that couldn't hear, is why do patients present differently? And I think what I heard you say is that some people came in very early with meningitis, and some people have these localized infections in their back. And what is that? And it's very interesting. This is this fungus. So one of the things that confounds this issue is that when people were injected with this medication, it's a steroid, and the whole purpose of getting a steroid is to reduce inflammation, reduce the immune response, because inflammation causes pain, essentially. That's why people had back pain, because they had what's called nerve root inflammation. So people who have a slip disc, their disc is kind of impinging upon their nerve, and you inject a steroid there to reduce the inflammation and reduce the swelling so that their nerve root will not be impinged anymore. So but the other thing that steroids do, they reduce inflammation, they also reduce the immune response, so that so if you think, and actually the half-life of this steroid is on the order of months. So you're injecting a steroid that reduces the immune response together with a fungus. So it's a perfect kind of media for this fungus to grow. And so why did some people get meningitis and other people not is a very good question, and we don't exactly know why some of these people went on to develop this infection, but we think it might be related to somehow the fungus is able to thrive in this environment. As I said, it's a steroid, and able to cross over. The spinal anatomy is very complicated, but essentially there's a protective sheath around the spinal cord. But somehow this fungus is able to cross over because it's a very aggressive fungus, get into the spinal column, and then cause meningitis. They've done a lot of work on this fungus in the plant world because it's actually economically a very important fungus because it causes crops to die off. So they know that this fungus can actually secrete toxins, if you will, that can kind of help destroy locally some of the tissues so that it can help invade. So this might be some of the reasons why there's this difference in how people present it. Well, we're still hearing about cases. And the last time anyone got injected, conceivably, is late September, when this product was pulled off the shelves. So between late September and now is about 6 months. So, but again, cases are still going on. We don't know how long it's going to be until the last person gets their infection. But certainly 6 months afterwards, we're still hearing about cases. And I think that's a really great point. The point was that essentially our calculations could be low because this product was pulled, and if it had not been pulled, how many more people would have been exposed? This product was produced, there were 3 lots that were affected, as I alluded to, and the first lot was produced in May, late May. The second lot was produced in June. The third lot was produced in August. So this contamination at this facility was going on since May, and consistently. For every single lot that was produced during this time period was contaminated. So would there have been a September lot? Yeah, of course there would have been a September lot. Would there have been an October lot? Absolutely. It would have just kept going until someone had recognized it, someone was able to finally call the company and recall the product. So absolutely, if there was no public health infrastructure, if people were not able to recognize this, many, many more people. How many? I honestly have no idea. I do not know how many lawsuits there are. I know that there are lawsuits. I think it's public information that there are also criminal proceedings against the company. I think there are class action lawsuits, but I wouldn't know. This is really a very trying experience for a lot of the patients. If you get a chance, go on 60 Minutes and click on the story. You can see the whole story from, I think it was the Sunday before yesterday, where they talked about this outbreak. And just to understand from a human perspective, these people that have really had to go through tremendous, harrowing ordeals. And it really humanizes this outbreak. It did for me, at least. And thankfully, no one in Georgia had gotten infected. But again, this is really a trying experience for a lot of these people. That's a good question. The question was, what was the source? Well, there are a lot of hypotheses right now. The FDA is doing an active investigation to find out where the fungus could have come from. And so I don't know what they've reached in their final investigation. I think if you go on, again, to 60 Minutes or you read some of these articles, you hear about, especially the recent 60 Minutes article, you hear from, there are actually some employees of this compounding pharmacy that kind of, first time speaking out. And they're talking about the conditions there and how they were just kind of, pushed to produce more and more product when, there were concerns about sterility and things like that. So, I can't say what the ultimate cause was. There's certainly a thought out there by the media that it was related to some laxity, but until the FDA investigation is over, I don't think we'll really know. Right. That is something that has confounded us a little while. If you go back to that slide I had, which goes state by state. One thing I want to show you, which is that the case numbers by state varies tremendously. And some of the states, like Michigan, for whatever reason, was really the epicenter of the outbreak. Here, this one. And and there was the one case in Georgia I misspoke earlier. It's hard to keep track of all these states, actually. One of the things that we don't understand is why there are some states, not just states, why there's some clinics that were really heavily hit by this. A lot of their patients got infected and other ones didn't. And we don't think it's because they're not looking for it. We think that everyone is looking for these diseases. But there might be something related to the way it was injected. There might be something related to if it was mixed with something before it was injected that might have led to maybe a prevention of getting this disease. But we really don't have a good handle on that. Yeah, sure. EIS, as I mentioned, it's a really fantastic program, and what it is, it's essentially it's a 2-year postdoctoral training. So you have to have a doctorate, and it's really a training program on field epidemiology. So you kind of learn by doing, and so you learn by investigating these outbreaks. For example, our officer Rachel Smith, her experience was investigating this, and it was really quite a tremendous experience. If you're interested in public health and you're interested in a career in public health, it doesn't matter if it's at CDC or in another aspect of public health. A lot of people end up doing EIS as a start of that career. And first, I would go online and look and see what the requirements are. Again, you need to have a doctorate degree. But assuming that you meet those qualifications, a practical experience is always helpful. But the thing that the office looks for most is a genuine interest in public health and a record that shows that you've been interested in public health for a long time and that you have an intellectual curiosity, that you've got this kind of disease detective mentality to kind of get to the bottom of what's going on, as this outbreak shows.
Just to throw a question in there, I think when you were in college or medical school, you did some work with Doctors Without Borders.
Yeah, I first got interested in public health when I was right after college, actually during college, I worked with Doctors Without Borders before I went to medical school, and then in medical school, I think things have changed now, but when I went to medical school, people did not emphasize global health very much, and I think things have changed now. I think there is quite an emphasis, but then, I started something called the Global Health Interest Group or something, and there were like 2 people in my entire medical school, it was me and someone else, and we met and talked about basically that we could do nothing, just the 2 of us. But that, I think now in medical school there are a lot of people that are interested in public health, a lot of people are interested in global health, and so that's how I got my start. Yeah.
And shed light.
Oh, absolutely.
Unusual infectious disease.
Yeah, and I'll just speak a little bit about fungi because we have some time, and just talk about how interesting they are, especially as it relates to plant sciences. As you know, fungi are everywhere; they're ubiquitous, and they are very important for crop sciences. But the other thing is that they're in the environment, and they are probably the only class of organism that has ever caused extinction. So there's 2 huge epizootics going on right now. There's something with frogs and there's something with bats. And in both of these, entire populations are being wiped out by fungi. In the bats, it's something called white nose syndrome. You might have heard about in the newspaper. And then with frogs, it's something called the chytrid fungus. And the reason why this is happening is because, for some reason, and there's a great hypothesis around this, some reason these fungi are developing new environments, and they're developing the ability to infect people, whereas before they hadn't. Not people, animals. And in the case of bats, they're infecting people when they're hibernating, and they're causing massive die-offs of bats. And if you think about it, fungi have existed on our planet for ever since there was life on this planet, and they've co-evolved with people. And one of the interesting things is that fungi are thermally sensitive. Some fungi they have certain niches. Like if you think about a mushroom in your yard, all of a sudden it rains, and it can rain for all this time, and then all of a sudden you get a mushroom sprouting, and it looks like it came up overnight. It's because they thrive. They have to have this very specific set of conditions to thrive, and one of them is temperature. And some people think that that the reasons why humans have an elevated body temperature is to protect themselves against fungal infections. Because actually, when you think about it, they're actually only, with the millions of fungi that are out there that are on the floor here, that are in the air, there are only a few of them actually that can cause illness in humans. And so one of the theories, and this is of course just a theory, but if these fungi gain thermotolerance, then there could be the potential to infect large numbers of people or animals or whatever. So that's one very interesting thing that kind of ties in ecology with public health, is what is the interaction between people and the environment and microorganisms. Well, in this case, if, for example, if the world were to become a hotter place and fungi were able to adapt to a hotter climate, then they might be able to be more suited for a human body temperature, whereas right now they're not.
Well, you always knew there was fungus among us.